All right. Hi, everyone. Hello, and welcome to this episode of Thinking It Through with Dr. Naidoo, Child Psychiatrist. Today, we are talking to Dr. Susan Rich, a distinguished fellow of the American Psychiatric Association, a double board certified child and adolescent psychiatrist and adult psychiatrist, and a certified equine assisted psychotherapist. Dr. Rich received her MD and MPH from the University of North Carolina, Chapel Hill. She did her adult residency at Georgetown and child and adolescent fellowship at Children's National Medical Center. She has worked for several years in all areas of psychiatry, including private practice and forensics, and I had the privilege of hearing Dr. Rich present at the Arizona Psychiatric Society's annual meeting back in April of 2023. There she presented the alphabet soup of neurodiversity, shifting psychiatric paradigms and clinical medication management. And the morning of our conference, I was one of the first people there. And without even knowing who Dr. Rich was, she came up to me and just started speaking so enthusiastically about her work and her children, and her passion and energy to help these kids is just so contagious. She has spoken far and wide about her specialty and passion, neurodevelopmental disorder associated with prenatal alcohol exposure. In layman's terms, this is called fetal alcohol spectrum disorder, or fetal alcohol syndrome is what people usually call it. She's written extensively on this topic, including a chapter from the textbook Autism Spectrum Disorders titled Autism Spectrum Disorder, Neurophenotype with Preconceptional and Prenatal Alcohol Exposure, a call for industry responsibility in prevention. She also has her own book titled The Silent Epidemic, A Child Psychiatrist's Journey Beyond Death Row. And in addition to all of that, she is the owner of a private psychiatric practice, therapeutic and learning centers, which provides an array of psychiatric and therapeutic modalities, including not just what we think about in psychiatric treatment with medications, but also farm animal assisted therapy, which is super exciting. She is also the founder of the nonprofit organization Seventh Generation Foundation, which operates Dreamcatcher Meadows, an inclusive green care farm animal sanctuary, which provides social, recreational, and vocational opportunities for youth and families that are neurodiverse. She's a champion for increased awareness, education, and prevention of ND-PAE, which is our acronym for Neurodevelopmental Disorder associated with prenatal alcohol exposure. And I'm honored to have this timely podcast right in time for FASD Awareness Day, which is September 9th. I'm thrilled to speak to her today on today's episode of Thinking It Through with Dr. Naidoo. Blame it on the alcohol, neurodevelopmental disorder associated with prenatal alcohol exposure. Awareness and Prevention with Dr. Susan Rich. Thank you so much for being here, Dr. Rich.
Oh, thank you, Dr. Naidoo. And I think it was just your warm, welcoming smile that drew me to you when I came out to Arizona. I was so happy to be there. And it's just such a beautiful state. I spent a little bit of time there when I was in medical school with the Navajo area of Indian Health Service.
Oh, wonderful.
And did a couple of different projects out there. So I was just delighted to be there. And you were so welcoming, you and all the attendees at the conference. But I had to walk up and talk to you.
Oh, well, your lecture seminar was fantastic. Just to give you a picture for the listeners, everyone else was speaking at a podium. Dr. Rich got out off the stage. She was talking, she was mingling. She just makes everything so real. I can see why her patients really love working with her. Is there anything else you want to add to your intro?
Well, I think one of the things that a lot of people don't realize is that 1 in 20 people in the United States have this condition that is due to prenatal alcohol exposure. And it's seen as the leading preventable cause of neurodevelopmental conditions. So conditions like autism, learning disabilities, ADHD, intellectual disability. And a lot of people mistakenly think that, fetal alcohol syndrome is the only thing that can happen, when in fact, that's really only about 10 to 15% of the kids have the full syndrome. And that syndrome happens in the late 3rd to early 4th week post-conception. So the babies that may or may not be exposed in that time window aren't going to have the facial features. And then another thing that a lot of people don't realize is that only 10 to 15% of affected children have intellectual disability. Most of them have a fairly, moderate IQ. So they might have in the 80s or 90s, and their executive function sometimes can be way low. And then that makes their adaptive functions not as high because they have a harder time organizing and planning and time management and things like that. But I know we have a lot to talk about. I just wanted to kind of clarify that. And that's one of my main aims, is to really disrupt the way that we think about this problem and to begin changing the paradigm so that psychiatrists can see these children a little bit differently. Everybody has their role in this world, of raising awareness about prenatal alcohol exposure. All the people that are kind of advocating around FASD Awareness Day. But every day should be FASD awareness, because every day people are drinking in our society.
Mm-hmm. Absolutely. So there's so much to talk about with alcohol and brain development and presentation. But before we get there, I just wanted to kind of take a step back and talk about terms, because I think there's been so many changes post-COVID with the awareness of mental health needs. Autism has changed in terms of how it's used to classify what types of patients, even within our DSM, which is kind of our psychiatric Bible, so to speak, for those listening. But there are lots of words used for young people and people of all kinds who are different. Different is one term, special is one term, challenged, cognitively impaired, neurodiverse, Asperger's, gifted, neurotypical. So all of these words are kind of floating around there. And I find myself even using the term spectrum instead of autism spectrum when I speak to people, because it's more palatable than autism. So I find myself as a psychiatrist, words are so valuable, but then it's also who is hearing the word and what are they able to understand. So if you could just give us kind of a primer on what are the right terms for us to be using as psychiatrists? What are the terms that everyday people might be resonating with? What does neurodiverse really mean?
Well, it's such a great way to open up this conversation, because I think the COVID pandemic, as you said, really caused a lot of what we now call the neurodiverse community to rally itself, because a lot of the young people were online, they were talking, they were chatting. There was a lot of, socializing online. And then people would hear from podcasters, or, they might listen to a webinar and they might learn some things, and they became very educated about what issues they had. And so really, I think these terms, these new terms that we're using, why they seem more palatable is that they're driven by the community itself, by the people who may have these conditions. And I don't like to say special. I don't like to say challenged. I don't like to say disability. I say different ability. So I may be a little different myself, and maybe I'm a little bit spectrumy. I don't know. My children tend to think so. My own biological children tend to think so. I'm not really, but at least my colleagues don't think so. But for neurodiversity, the idea is that we really all are neurodiverse as a human species. And the reason that this term resonates for so many people is that we're not saying one is better than another, or one, it doesn't give it as a this person is doing things in a way that's that may be normal, right? And another person is abnormal. It's that this is a typical way that people act or behave or conduct themselves, and this is an atypical way, but one is not better than the other. It gives room for society to then embrace differences. And just like we've embraced differences in, let's say, skin tones, or in whether or not you can walk, unassisted, right? Some people may have a walker or a cane, or maybe they're in a wheelchair. And these areas of inclusion then in our society have opened up, with neurodiversity being, or the neurodiverse population being, the last frontier in inclusion. So when we use some of these terms, neurotypical versus atypical is like saying vanilla versus chocolate, right? In my view. And why it's spectrum, it's like, okay, it's like the color spectrum. There's nothing good or bad, right or wrong, there's no judgment on that. And that's why I think we can all embrace that idea. And as psychiatrists, I think we do stigmatize patients by using terms like psychopathology, to be honest. And I think I mentioned that at the conference. I think that if we ourselves in our field could stop pathologizing people, then they wouldn't feel so stigmatized. And so, in my humble opinion, I think we as psychiatrists are as guilty as Asperger himself. The reason we no longer have that term, you can read a historical account of that. Do you know much about that? Or
no, please share.
Well, so the reason that we don't use that term anymore is that Asperger himself did write letters to the German government to get children put in asylums where they were then gassed. Okay. And the first 4 gas chambers that the Nazis came across were in state psychiatric hospitals in Germany. And so they had taken those 4, disassembled them, and reassembled them in the prison camps. So there is a very lovely historical account of this written in a book, and I can't remember the name of the book, but I came across the book a couple years ago, and I don't know if that went into why the APA decided to remove Asperger's syndrome from the DSM, because there was no fanfare about it, there was no publicity, there was no newsletter or anything. It just kind of got withdrawn. And a lot of what goes on, as you know, in those work groups for DSM, it's not privy to the public or to even those of us who are in psychiatry.
Right.
But the neurodiverse, I feel like the neurodiverse community has come out to say, look, just because we don't fit into the middle of the bell curve does not mean we are, worse than, or that we're challenged or anything like that. The challenges come from a society that is not willing to accept differences. And we have to underscore that. Right.
And I think for, just for the listeners who may or may not be aware of this, so our DSM is kind of our guidelines as psychiatrists for other psychiatrists to communicate with each other. It's really not meant for those who have certain categories of symptoms to self-identify. It's really so that I, Dr. Naidoo, can talk to Dr. Rich, and we both know, okay, if someone has this label, they probably have these kinds of symptoms. It's a categorical way, so we're speaking the same language because people look so different. So a few years ago, autism spectrum disorder was reclassified, and there was one diagnosis back then called Asperger's, which was kind of like a very, very mild form of autism spectrum disorder. And what they found was that people who were diagnosed as Asperger's were not getting services and support. So the DSM was reclassified to take away Asperger's and have them included in autism in the hopes that they'd be able to provide and obtain more services. However, in my clinical experience, I don't know about you, Dr. Rich, I found so many adults and children who have identified with that particular form of autism as Asperger's, feeling it stigmatized them more, because they don't they don't identify with those in the middle. And I think that's the challenge that you work with all the time, Dr. Rich, those kids that don't quite fall into any of those clear categories, the kids that fall between the cracks, but still need help. And I think that's where my sense is that that's why it was so important to push for ND-PAE to be in the diagnostic criteria for the DSM. Is that accurate?
Yes. So ND-PAE is a separate kind of issue, because it then brings up neurodevelopmental disorder associated with prenatal alcohol exposure, going along with what you just said with the new DSM-5, which came out in 2013,
Mhm.
all of what used to be categorized as childhood mental disorders or disorders that present themselves during childhood were reorganized into neurodevelopmental conditions. And that was when the Asperger's was taken out, a new term, social communication disorder, was put in.
Yes.
And then a lot of the kids would either go into social communication disorder or high functioning autism.
Mm-hmm.
And as you said, the problem with doing it that way is that really no one is diagnosing social communication disorder outside of speech and language pathologists.
Mm-hmm.
And social communication disorder is really up under, it still should be up under, in my humble opinion, the autism spectrum, because it's a pragmatic language problem. It's a problem communicating with peers. And, you know, a lot of the same reasons that people on the spectrum feel isolated and socially disenfranchised is because they have difficulty communicating with peers in the back and forth way. So it's kind of like a tennis match and a conversation, and you volley and then the other person, you know, volleys back, and you're talking back and forth with one another, and you're deepening the conversation. They have a very hard time doing that. So that said, ND-PAE is a little bit separate from that because it was originally in the first DSM-3 in the DSM-3. And by the way, DSM was never supposed to be used for insurance reimbursement purposes. It was never supposed to be used widely the way it is. It was mostly for psychiatrists, like you said, to be able to really create a treatment plan around certain issues and to be able to do some research to figure out which medications would work better for one condition versus another. But it was never supposed to be used in the ways that we are in society.
Yes.
That said, it isn't based on etiology, unfortunately. And etiology being what actually caused the person to have the problem that they have.
Right.
So with certain exceptions, so post-traumatic stress disorder, we know in the beginning was coming out of wartime. And if you had trauma, so that was an etiology, that's how the thing, you know, happened, how this condition happened for the person. That is one that is etiologically based. And there are certain other trauma diagnoses. There's reactive attachment disorder, which oftentimes is associated with adverse childhood experiences, what we now know of as adverse childhood experiences. But it doesn't mean that a child can't have reactive attachment disorder who grows up in a middle-class family and maybe the parents are treating them, you know, harshly or cold, or they're ambivalent toward their children. Maybe they're having marital distress. And, you know, we could pick out as child psychiatrists that there's a lot of family disharmony and a lot of chaos and a lot of stress and maybe some neglect of the child psychologically. And we could help, you know, understand that. But as a society, we really don't think of some of those things as either abuse or trauma. So etiology, then, how something happens, we know from neuroteratologists. These are people who study how development is affected by chemicals and different environmental insults. It could be stressors on the pregnant woman, but these are things that happen very early in a pregnancy. And now we know that some of these things are epigenetic, meaning male sperm can be affected by things like alcohol and methylate the DNA histone proteins. These are, you know, regulatory systems that then would cause multi-generational changes. And that's one thing that alcohol does as well. So the reason that I have felt all these years that it's so important to get ND-PAE and DSM-5, as have many, many other people. The Interagency Coordinating Committee on FASD was very big in helping push to get it in DSM-5. They didn't have any MDs on the committee that worked with the substance abuse work group to get in the at the end of DSM. They have under conditions for further study neurobehavioral disorder associated with prenatal alcohol exposure. They did not get it in the front end. What we did get in the front end is under F88, which is other specified neurodevelopmental disorder. We have ND-PAE listed as an example under that, and it's on page 86. So why is ND-PAE important to be distinguished from, let's say garden variety Asperger's, or not Asperger's anymore, but autism spectrum?
Yes.
The reason, in my view, from a public health point of view, because remember, I did a Master of Public Health and Health Policy, and I did that before medical school. We need to be able to count these children. So if CDC is estimating it's 1 in 20, the Centers for Disease Control and Prevention has done, rigorous studies. They've determined on, a number of, in a number of these very large studies, that it's about 1 in 20 American children have this problem. Well, where are they? Why are people not talking about this? It's because they're being lumped up under a lot of other diagnostic categories. So for us as child psychiatrists to be more public health oriented, which I understand we're not, although we do have a little bit of public health training in psychiatry. If you remember, we have some epidemiology, statistics, those types of things. But if we really are going to be preventive, then we need to not only be able to identify these children and start counting them, because to say, hey, alcohol is causing this problem, where is it happening more? What populations may be more affected? What interventions do help with women who have alcohol use problems, or men too? How can we get contraceptives more readily available in those communities where this is a big problem? Because if you're sexually active and using alcohol, you need to be contracepting. So to rally any type of public health initiative, we have to have data.
Right.
And one of the biggest data points is, how many people are affected, and what some demographic categories of the individuals, where are they living, and that type of thing. So that was really the big emphasis and impetus for getting it in DSM-5 was, can we start counting these? Now, given that it's up under F88, which is other specified neurodevelopmental disorder, you could have, anything from Klinefelter's, right? Genetic disorder that is, they do have neurodevelopmental differences. Some of the individuals do have, are, classified under the autism spectrum, but let's say they didn't meet full criteria for autism spectrum, you could put them up under other specified neurodevelopmental disorder. And then that way, in fact, you're still getting lumping instead of splitting it out based on etiology. So what I had advocated for with the DSM-5 work group, that when I interacted with them, was, hey, we need to be able to put a separate code. And if you're going to put it under F88, for example, then put a 0.1 and say that's the prenatal alcohol exposure. And the pushback that a lot of psychiatrists give, and I don't know if you're familiar with people who have this attitude as well, I wasn't at the bar sitting next to her drinking, so how do I know the birth mom drank? Right? And because they don't have evidence. And to make the diagnosis of ND-PAE, you do have to know whether or not the birth mom drank. And birth dads who drink, because of the methylation effects, it makes the baby more susceptible to the mother's drinking. And let's say she stopped at 8 weeks when she found out she was pregnant. Well, then that's now the embryo's done developing. It's now in the fetal stage, right? Organogenesis has happened. But then when she reports it back to her doctor, the doctor will say, OBGYN, you didn't drink, did you? And she'll say no, because she didn't drink after pregnancy recognition.
Right.
Some women don't. So yeah, ND-PAE is, best understood as among the neurodevelopmental disorders, and it can mimic almost every neuropsychiatric diagnosis out there. So I do think that we need to count these kids because we need to mount a public health response.
And it sounds like there's so many levels to what you just spoke about, but just to reframe, for the listener, Dr. Rich is basically saying that people can present very differently, and having neurodevelopmental prenatal alcohol exposure can encompass a broad spectrum of presentation. So kids or adults may present with symptoms of anxiety or depression or ADHD or even intellectual disability. They may or may not qualify for fetal alcohol syndrome, but they still may have the symptoms of being exposed to alcohol in utero. And what I also want to underscore, which I was not fully aware of, is that alcohol can affect sperm in such a profound way. To just like if an older man has children, they're more susceptible for certain neurodevelopmental disorders. It's not a guarantee, but they're more susceptible. The same is what you're saying for alcohol. And in my clinical experience, my prior job, I dealt with a lot of kids who had intergenerational trauma, intergenerational substance use. So I would see a lot of children present with their grandparents because their parents were in substance abuse treatment or out of the picture. And very often the grandparents were so concerned would say, the mother was using A, B, C, D, E, but I'm the paternal grandma. Yes, he drank, but now he's sober and he's in the life of this child, and kind of really discredited the male role in the challenges happening for this child. So I think that that's really fascinating and important, because I think, as we know, as women, oftentimes the mothers get a lot of the blame for how things go down. But understanding there was also, it's both male and female counterparts using alcohol can really increase that susceptibility to having ND-PAE. And the other question I have for you, Dr. Rich, given that we're talking about diagnosis, is in this context clinically, is I'd have a lot of grandparents ask me, what's going on with this child? I know something is wrong with them. I have other grandkids, I have other children that I've raised, and something is just off with them. And they would really be at me to get a diagnosis, because people are also kind of, I think the medical model has developed a society who is used to having a diagnosis to understand the etiology of symptoms, which is really not how psychiatry works, which is as you just described. I had one grandmother who said to me, because I explained to her, they don't quite have autism spectrum and they don't have intellectual disability because they had neuropsychological testing. Yes, they have symptoms of ADHD and they have anxiety, but I don't think that is really it alone. So this grandmother in particular said, I think this child just has bad brain syndrome. They just have a bad brain. And for her, this was deeply alleviating, because she could explain the challenges that she had in raising this child as this child was born with some kind of drug in utero, they have a bad brain. And yet, when I think about this child hearing their grandma say, I have bad brain syndrome, you think about this child developing with that as the frame. So I think it's really important that you've described, this is the value of using terms like neurodiverse, neurotypical, or not neurotypical, to really help even the playing field, so that we as mental health care professionals and guardians, in trying to understand and make sense of something that is so complex, to not further stigmatize young people and how they think of themselves, because I think then they develop with this expectation of, well, I can't do this because I have a bad brain. I can't do that because I have a bad brain. I'm going to act out in school because I have a bad brain. We are molding our children even post utero, right? The environment continues to mold them. So I think how we speak about children, the language we use is so valuable. But I'm curious, Dr. Rich, if a grandma like this came to you, how would you think through talking to this grandma, explaining to her how she should think about this child, talk to this child, treat this child?
Well, first of all, I really appreciate your perspective on this because I see grandparents all the time, all the way back to my training program at Children's National. I had a clinic there when I was a fellow at Children's National Medical Center. I had worked under Dr. Paula Lockhart at Kennedy Krieger Institute, which is affiliated with Johns Hopkins, who ran a FASD clinic, Fetal Alcohol Spectrum Disorder clinic up at Hopkins. So I had done a 3-month rotation with her. As you know, during our fellowships, we can subspecialize. So I had done that with her. And then I went back to Children's for my last 6 months of my fellowship and ran my own clinic.
Wow.
And we got calls. I would just have the front office person screen the people calling in for appointments to say, is there a chance that this child was prenatally exposed to alcohol? Whether the birth dad or the birth mom drank, is there knowledge of that? And it turned out I got 17 individuals referred to my clinic just from the front office screening like that. And I saw each child every week. I did parent guidance with their parents. I had a lot of grandparents bring their kids in because it was DC, you know. So in my private practice, when I set that up in 2006, I continued doing the work. And I have had, because of my talks at foster parent associations and that type of thing, I have had people come. So getting, grandparents coming, kinship care, they're in kinship care. So talking with the grandparents, what I often say is this child is a gift that has come into this world. They have survived a toxic womb, and they are more resilient than many, many people ever will be.
Wow.
Because they have you raising them, and they have, so it's a knowledgeable, expert parent raising them, meaning this is somebody who's already raised other children. They know what differences are. And this child's brain is going to be very unique. So there's going to be superpowers they have, and there's going to be strengths they have that really very few people have, because in order for that child to have survived a toxic womb, they have to have, some differences. They have to have some way of surviving. So with survival of the fittest, as you know, many of the babies do die in utero who are prenatally exposed to alcohol. So the ones that do survive are going to be the ones that would have been, let's say, Einstein. Okay. And they're the ones who, if you get to know who they are, which is what my farm, animal assisted therapy allows me to do, that a lot of people don't have the opportunity to do, you can see that they are either perceptive in many extraordinary ways. Maybe they're sensitive to their environment. They have like extremely good hearing, or their sense of smell is off the charts, or their taste buds, which is why we give them these terms like sensory sensitivity or sensory integration issues. A lot of them have interoceptive problems, which is not being able to pick up on their internal body cues, and that will dysregulate them.
Yep.
But once you figure out where they fit into the 4 domains, so social communication, neurocognitive, sensory and motor, and then mood dysregulation, autonomic arousal, and how all 4 of those things impact their adaptive functions, these kids will thrive. But you have to understand it's not just the domain that we're brought to our attention, which is mood dysregulation, autonomic arousal. They have all the other domains. And if you remember from my talk, I shared the slide with those 4 domains. And for child psychiatrists, it's easy for us to wrap our minds around that Venn diagram. But the Venn diagram wasn't shown to us because, I was the one who came up with it, right? And based on my work. And so I try to teach people that, look, your child is a gift. You decided to help raise this child because you believe that. You did not encourage I have one set of grandparents who come for parent guidance every 3 months or so, and their little grandson is he's off the charts bright, but very, very impulsive. And he would talk nonstop, which really aggravated the grandmother. And he had a hard time like engaging with the pandemic related computer, schooling, the virtual
Online,
schooling.
very difficult for a lot of these kids.
Right. And so she was having to be on him. She would use loud, voice and just very demeaning. She didn't realize she was doing it, but very demeaning to him. And the grandfather actually was the first one to come in. And I said, look, I said, I cannot meet with just you. I said, I have to meet with everybody because everybody has to be on the same page about him. And everybody needs to believe the same thing you do, which is that he has value, and it turns out that he's now, this boy is now thriving. He's only on, one medication. And I think for a lot of these grandparents, they don't know how to settle themselves down enough.
Yes.
And regulate themselves when their child goes into the kind of what I call limbic seizure, when they go into this, autonomic arousal and they shunt to their emu brain, their very deep brain, they can't get out of it. And no matter how much you scream and yell at them, they're not going to be able to get out of that. So the parent themselves has to learn mindfulness. And they have to learn positive parenting approaches and using humor to deflect anger, but not in a like patronizing way or off-putting way, but just, kind of to cajole and, get them before they go into the full-on rage.
Right.
So you had also mentioned about not knowing about the birth dads, and I do have a number of birth dads in my practice who get back involved with the child after they are clean and sober if they're in kinship care.
Wonderful.
And I think that's really the best approach over foster care. Like the parents seeing this child being raised by their own parents, often which they don't have very good relationships with, but seeing this child grow up and thrive, it then gives the parent motivation to get clean and sober. And really, when you make this diagnosis, it's a diagnosis for two, right? It's not just a diagnosis for the child, it's a diagnosis for the parents, the birth parents, and we have to get them into treatment. And doing it in a way that's acceptable to that parent, is the problem oftentimes. Having access to the parent, like if you see a child that's been adopted, obviously you wouldn't have, any conversations with a birth parent. But for people who do, like the foster care system, it's really important for them to help the parent with the shame and the guilt and the self-blame, but to also acknowledge the fact that, hey, this is what happened to your child, and now let's be kind to them, and let's gently raise them with cocooning so that they're not overstimulated and overwhelmed by a world that doesn't understand them. Let's create a world that's a little bit better and more sensory softened, so they can live in the world more peacefully. Absolutely. I don't know if that helps you understand my frame on the grandparents. On parents too, there are a lot of parents that have adopted these kids from Lithuania or Russia, even foster care in this country, Eastern Europe. But I've seen kids with this problem from the Philippines, from Guatemala, from a lot of these countries where American tourists have gone in, and there's this huge influx of alcohol, and very poor communities where prostitution is rampant, and sex trafficking and that type of thing, and children end up then getting left on doorsteps of police stations or orphanages or wherever, and eventually some of them do get adopted by Americans.
Mhm.
So we, over a 20-year period, brought in 60,000 Russian and Eastern European adoptees to this country.
Mm.
And that's a lot of, if you consider at least 50% of those have some degree of ND-PAE,
Mhm.
then that's, something for parents to kind of start to look into and to question. Is the fact that my child they're not thriving in their school system. They don't have any friends. They're not, wanting to do the same type of recreational activities other people do. They have a hard time when we go out in public, to eat dinner or do other things, and their mood outbursts are just off the charts. Is it possible that they have a condition like this?
Mhm.
And, I think the more parents are aware, whether they're grandparents or the biological parents or even the adoptive parents, the less shame they're going to cause for their child.
Mhm.
I consider this as a brain-based condition. It's a neurologic condition.
Mhm.
It's not like all in your head. It's not from, the worried well. It's
Mhm.
not from like just somebody who worries a lot and, they have problems related to that. This is a brain-based condition. And I describe it as differences in their biological wiring in
Mhm.
their body. We have our autonomic nervous system, our sympathetic and parasympathetic systems, as well as our peripheral nervous system, our central nervous system. We have all these cells that are called neurons that extend all over our body. And prenatal alcohol exposure can affect all of that. It also affects other regulatory systems in our body. So our endocrine system,
Mhm.
our metabolic system. It's why a lot of these kids tend to be either really thin or after they go through puberty, a lot of the girls get overweight.
Mhm.
Um, it affects their digestive system, their circulatory system. Studies have shown that even their, as their fingers develop, they don't develop all, of their, the joints, as long as other people's.
Mhm.
That's considered partial phocomelia being where you're missing an entire limb, but partial phocomelia, a lot of them have a smaller last kind of on their finger digits. Yeah. The last joint is foreshortened, and
Mhm.
their nail beds tend to be foreshortened, but the circulatory system underneath that, underlying that is also foreshortened. So anyway, having said that, it's not just as simple as saying, oh, these kids have fetal alcohol, let's throw them into a warehouse situation like used to happen. We're going to have to be able to figure out what is going on with each and every one of them and find their strengths and help them capitalize on their strengths. Just like a tree that you might prune in the fall, you
Mhm.
prune the branches. Well, these children are born with pruned, overly pruned neurons because the prenatal alcohol affects their development of their neurons. And then by the time they're in their adolescent years and all of the, dendritic changes are happening, they will regrow or, form new connections. The
Mhm.
problem is that's also the time that their hormone system is changing.
Right.
And that's exactly the time that a lot of these kids look like they are mentally ill, is a term that people used, because they are so disruptive at home, school, and the community. But
Mhm.
if you can soften things while they're going through this rewiring, they come out the other end of it better than if you just keep on stressing them with a lot of homework, a lot of, overstimulation at school, yelling at them for not doing their chores, things like that. You don't want to stress them in that way. Anyway, I mean, I have a lot to say about it. I've
And
probably.
it's a fine balance with kids too, because as teenagers, we will often have parents come in and say, this is the challenge we have with our teenager. And it's a fine line between making recommendations for parenting styles versus managing symptoms versus really challenging young people to be resilient. So it's really knowing the family and getting to know what the family is capable of implementing, what the child is capable of tolerating, and what they're willing to hear. Because we can say one thing and then what they do is a totally different thing.
I
So
know.
I bring that up because I think I wanted to have us talk a little bit about prevention. Because if we think about of course, there's the opioid epidemic that has gained a lot of traction in terms of prevention and treatment, with Narcan now being in Walgreens and CVS. But when I think about alcohol is so pervasive. So when you started by saying 1 in 20 young people may have this disorder, if you think about how much alcohol is advertised and socially acceptable, that's surprisingly small, because there are so many people that are using alcohol day to day, whether they are fertile or not fertile. So I'm curious, from a prevention perspective, how have you, I know you've done some of this work with prevention with young people. Speak to me a little bit about how we can really help spread the word, to talk about the need to prevent alcohol use during this phase when it is so accepted.
Well, it's a really big problem, as you said, not just for this phenomenon, but also, with alcohol, but also for, prescription medications, which, as you know, we as physicians, if we're going to put a woman on lithium,
Yep.
or for dermatologists that are going to put a woman on Accutane, we're going to say, you need to be on a contraceptive to get, even for a 13-year-old to get Accutane, which is for acne. It's a retinoic acid derivative, which can cause birth defects.
Yep.
So the dermatologist will see her 5 months in a row and do a pregnancy test every month, and make her sign that she's on a reliable contraceptive. Most dermatologists will actually prescribe the contraceptive. Okay. And I've had a number of young women come through my practice who have to go through that process because of acne, right?
I actually went through that experience and at that time I was not sexually active, but I had to sign something on a legal database that filed what I said, and I had a pregnancy test, even though I said I was not sexually active, to get the Accutane. So yeah,
right,
that's very strict about certain medications. So I think, so yes, you're drawing a
so
parallel.
This is what I'm getting at. So, however, any day of the week, a 21-year-old or over individual, whether they be male or female, can go into a now vape shop, can go into a convenience store and buy cigarettes, can go into a marijuana store in a lot of states, and can certainly go into an ABC store, an alcohol beverage store, to purchase alcohol without anyone asking anything about pregnancy status, their contraceptive status. Are they sexually active? Are they using contraceptives? And the really dirty underbelly of this whole problem is that our whole society, all of the socializing, even with the FASD United, which is the national organization, it used to be National Organization on Fetal Alcohol Syndrome, they even have cocktail parties at their fundraisers where Big Alcohol funds their fundraisers, which is why I'm no longer on their board. Okay. And really, we have to then examine some of these policies that are in our society, and we have to say, okay, if you're going to sell alcohol, in addition to having, let's say, maybe a sign up, which recently there have been studies showing, and over the years, that the signage, people don't look at it. We have a tiny little label on the alcohol that was mandated, finally put into the system in 1989. After the original Surgeon General's warning in 81 said that these problems happen very early in pregnancy. they still only put pregnant women should avoid alcohol because of the risk of birth defects.
Mm-hmm.
So we need to take a step back and say, is it just pregnant women that need to worry about this? Isn't it also if you're childbearing potential?
Mm-hmm.
So if you're sexually active and using alcohol, you need to contracept to avoid unintentional exposure to your offspring.
Mm-hmm.
And males and females need to do it.
Right.
So there's a drug called thalidomide. I write about this in my book. But there's a drug called thalidomide that you may remember. It came out in the late 50s, early 60s.
Mm-hmm.
It was worldwide except for the US, but some American citizens did get it because they were living abroad,
Mm-hmm.
or they were GIs, stationed
Mm-hmm.
somewhere else, the wives of GIs, or in the military.
Mm-hmm.
And thalidomide was used as an anti-nauseant for women who were pregnant. So it was actually given in the early stages of pregnancy, when all the major malformations happen.
Right.
And in the US, the reason it wasn't released on the market was that someone at the CDC who had just come in to the CDC had said, well, wait, we need to wait on the monkey studies because all the other studies were done in rodents. And the development in the primates is very different than in rodents.
Yep.
So sure enough, by the time all of the babies were born with phocomelia, which is because their long bones didn't develop, and a lot of other birth defects from thalidomide, the monkey baby experiments were coming out showing the same thing. And they were proving that it was from the thalidomide. So having said that, thalidomide was withdrawn from the worldwide market. Now it's being brought back, and over the last 10 to 15 years it's been brought back for use in things like leprosy, and I think even HIV. There's certain aspects of the HIV problem that thalidomide can help with. But in the event a physician is going to put a person on thalidomide, they have to be on 2 reliable forms of contraception. So, and it's just like what you said, you have to sign that you're either not going to be sexually active, or you need to be on a contraceptive yourself, like a birth control pill or IUD or the Implanon. And you have to agree that your partner is going to be using a condom. And this is whether a man or a woman is on the thalidomide. Okay. So we need to then take a step back and say, just like the CDC has recommended all the way back to I think it was 2015 or 16, it was February 2016 maybe. They recommended that sexually active childbearing age alcohol consumers need to use reliable contraception. So when you say alcohol consumers, that's male and female.
Right.
Because up to 3 months prior to conception is when the male sperm are developing. So it takes 3 months for spermatogenesis. This, you remember that all the way back to health class in like 6th grade, right? It takes 3 months for the sperm to develop. And then in that 3 months, it goes from the having 4 times the amount of DNA to, remember, the half the amount of DNA that it needs. And then it's ready to fertilize the egg. And it's the process of developing into the, I guess, insemination form of the sperm that the alcohol is going to affect the DNA. And it's not the DNA itself, it's actually the histone proteins that the DNA wraps around. And so what happens then, and it's transmitted through the generations, is the DNA can't unwrap to then be transcribed into mRNA and then into the proteins, translated into the proteins that are going to make things like serotonin and norepinephrine and it depends on where in the genome the methylation effects happen on the histone proteins, like which part of the DNA is locked. That locking, it doesn't affect, say, meiosis, or mitosis. What it's affecting is transcription and then translation. So, and I know all of this is like really heady and, may be getting into a little bit more detail, but it's just to say that it does, affect the male sperm, and those effects can last for generations.
And how come alcohol versus other kinds of drugs, why might that affect the sperm more?
Well, and in fact, I'm not sure that they've done a ton of studies on a lot of other things, but I do know that alcohol is a solvent. So as a solvent, that means it's kind of like bleach. Okay. If you put it's lipophilic, meaning it loves permeating through lipids. And if you look at water as an example, and you put like let's say oil in water, the oil is going to float at the top. But if you put oil in alcohol, it doesn't necessarily, it's a solvent. It means things dissolve in it that normally wouldn't. That's why alcohol is used in a lot of chemical, processes. It's why many medications are dissolved in alcohol, because it will hold them in solution form. It will hold certain things in solution form better than, say, water would. And so the long and short of it is, because it's a solvent, it's a really tiny molecule. It slips in between the membranes of almost every place in any organism. Meaning, in the human, it goes, we drink it, it goes in to our stomach, it goes out the stomach lining into our bloodstream. It then travels through the system. I mean, it's going to go into our liver. It's going to go into a lot of the systems. It's one of the reasons we have breast cancer. It's one of the leading causes of breast cancer in women. People don't realize it's a carcinogen and a mutagen. And it goes to the brain, which is where it has the effects that it has on people. And that's why they like to consume it. It's why it's consumed as a beverage, even though it's really a drug. So it's something for us to start thinking about, why alcohol? Well, I'm not saying that, alcohol is better or worse than any of these other things, marijuana or vaping or cigarette smoking, but we do know there are different effects of alcohol because it is such a tiny molecule. And because it's a solvent. I mean, vaping itself, I mean, not that that's what we're talking about, but it means it's a vapor. So it's that too is a solvent. It's just whatever you're dissolving in the vapor, the solvent that then you breathe in is going to then impact you however it does. But the solvent itself that's in the vape is that's not like just drinking water either. That's harming the body. And but we don't really think about it. I think that all vape shops, I think that all of these marijuana distributors, I think that every alcohol distributor should be required to not only have their product labeled, but they should also have to, in their advertising, it's a truth in advertising problem. It's a duty to warn the consumer. And this is a lot of what I talk about, Dr. Naidoo, that I've written about, is it's a consumer protection issue. This is a women's rights issue. It's a children's rights issue. It is in ways, a right to life and a right to choose issue, right? It's an issue that impacts so many different levels. It's impacted the criminal justice system, because many of these individuals do end up in prison, or in jail, or for, committing dubious crimes. These aren't highly sophisticated crimes. And, I think our society needs to kind of wake up about the issue. And with tailgating and with social parties and political events so driven by, alcohol by this industry. We need to hold the industry accountable the same way that the prescription drug industry for the opiate crisis, the opiate epidemic, is being held accountable. We need to recognize this as an epidemic of our social drug of choice. And you know as much as I do what that drug is, even though marijuana may be taking its hold on the whole society. Alcohol itself is our social drug of choice, and I do believe we need to get real with that and bring the industry accountable for the effects that its beverage has caused without telling the truth to the American public of really the harm that it has caused.
And what I will share clinically is working with teenagers, mainly working with teenagers and children. Of course, the focus and concern now is vape, nicotine, black lung, and marijuana. But whenever I do a risk assessment of a child, I ask about alcohol. And so often parents are very worried about nic and vape. They forget about alcohol completely. And I ask almost every child I've asked who've said, yes, they have tried vape or vaping of nicotine or cannabis, have also tried alcohol. And where do they get the alcohol? It's from home. They have to go out of their way to get nicotine and cannabis, but in their home, they know exactly where to go to get their alcohol. And for me, if you've been listening, you know that my passion and commitment really is for prevention of suicide in youth. And of kids that come to the emergency room in a suicide attempt, typically it's 50% that have a blood alcohol level that's positive, because that alcohol disinhibits decision making and good judgment, and with that also is increased sexual activity. So it really, use of alcohol and the readily accessibility that our youth have in our homes really can permit a lot of physical indiscretions, sexual indiscretions, which lead to this increased risk of ND-PAE that we're talking about here.
Yeah. And, Dr. Naidoo, I make a point of talking with all my adolescents, but particularly those prenatally exposed to alcohol. And I tell those prenatally exposed to alcohol, I say, you have had enough alcohol for 10 people in 10 lifetimes before you were even born. You don't need it anymore. And there are switches in your brain that will be flipped if you use alcohol, tobacco, other drugs of abuse. I'm talking about vaping, I'm talking about marijuana. And you know as well as I do that the individuals who are at highest risk of early onset psychosis is the population I'm talking about.
Yes.
And so I tell them, and I tell their parents, I say, shame on you if after I tell you this, you do not get rid of every drop of alcohol in your home. And if you drink in front of them, shame on you. And that's why, okay, you either come to me and you get advice and you take my advice, or there are way more psychiatrists in the greater DC area that are way more knowledgeable than me about many conditions. And you can, basically go and see them. But if you're going to work with me, you have to create an environment for your child where this social drug of choice is not accessible. And don't be going out to your, local, pub and taking them to dinner and let them see how many you can pound down. And don't be having, wine with dinner right in front of them. If this drug has caused this problem for your child, why would you even look at this stuff? If you're right now having to deal with your child with these rages, which I'm telling you, their brain is prenatally exposed, they are affected by our social drug of choice, and you're still choosing to consume alcohol in front of them, I can't even, make a comparison to what that is like. It's like slapping them in the face or saying they don't matter in my view.
So what you're hearing, if you're a listener, is the level of integrity that Dr. Rich has, right? She is saying she wants her patients and the people that support her patients to practice what, they're preaching and she's preaching, and to learn from choices that have impacted their life. And I think all of us as psychiatrists, as doctors, we have the things that we accept and don't accept, the things we're willing to work with and not work with. And that varies based on psychiatrists. I mean, some, you know, some of us will take care of young people that are actively using substances. Some will not. Some will work with those who are smoking nicotine, but not alcohol. And I think for it's very important to know that how we practice impacts the progress and potential growth and treatment and recovery of the people we work with. So it's really encouraging to me that you are not only being firm on the boundaries that you know will help with their physical and mental health, but also their longevity, and also giving them the option to find someone else if they don't work with you. But I think that as a consumer, as a potential patient, if you're listening, I hope that you're also hearing that there are a variety of us that choose to be firm when we need to and flexible when we need to. And there are lots of options for you. But it sounds like it's also really important to hear the psychiatrists and doctors like Dr. Rich, who are not just treating that child. They see treating that child as treating the system surrounding them, the parents, the environment, the social structure. So I really admire you, Dr. Rich, for having that passion, that integrity and consistency with your message.
Yeah, and the other message that your thoughts had brought up just a couple minutes ago, Dr. Naidoo, is you had mentioned your passion about suicide prevention. And I can tell you that this population of children and adolescents are at very high risk of suicide. There is a very high correlation between prenatal alcohol exposure and suicide, and as well as drug overdose. So if you look at who ends up, and one of the reasons I'm so firm with them is that who ends up in the ICUs or needing the Narcan, or really, unfortunately, having overdoses that end in death is those with prenatal alcohol exposure. There are a lot of other kids that are at risk too, but because their brain is a bit different and their brain wiring is a bit different, their autonomic system is different, their arousal is different. They are at much higher risk, the same way that babies prenatally exposed to alcohol are at much higher risk of SIDS. So when you see the correlation between sudden infant death syndrome, it goes back to their very deep brain, the limbic brain, and the brain stem, and how different it is, and why they're at higher risk of a condition like SIDS. But it's also true that when you depress the brain with a substance like alcohol or marijuana, and remember, these are central nervous system depressants, the opioids, fentanyl, cocaine, well, it's a stimulant, but these are the kids who would have the cardiac arrest, for instance, on cocaine. They're the ones who would pass out and be unresponsive on some of the opioids. So I'm firm with the kids, and a lot of the kids I work with, I start working with when they're 4 or 5. And by the time they're, 8 to 10, like, we're having conversations about why their brain is the way it is and why there are certain things they can do, versus shouldn't. And I talk to them over and over about it. And you have to have a good relationship with your patients. I really like working with neurodiverse kids, and I love working with their families. And I think it makes a difference when we talk to them and teach them. I take apart a brain. I have a model brain in my office that I take apart. I show them the different parts of their brain and how the parts affect each other, and how we can take it to our higher level brain functions when we're anxious. But when we are using substances, it disinhibits. Like you said before, it causes them to do things they wouldn't normally do. Their reality check is completely offline, and they may not even remember the next day what's happened. So this is all, I feel like, important to tell them before it happened in the first place.
Yeah. Yeah, and I think some doctors don't take the time to tell them, right? They just expect that and their risk is high to use an experiment more than other kids, because they have that dysregulated sense of self, mood, regulation, thought process, and they're more prone to get addicted when they do start using. So it's very important to take that time to really educate them and give them the awareness, and they make the choice, but we try our best to guide them in the right direction. So I did want to shift a little bit to treatments, because I know that you also have experience with equine therapy and with farm animal assisted therapy. So I'd love to hear more about this as treatment. In my own experience working with these children, I have found that they have not responded in typical ways to medication. This is my clinical experience, with not just with those exposed to drugs in utero, but also autism spectrum. Things just don't work in the same way as they would in more neurotypical clients. And sometimes we need to use alternative treatment. And equine therapy is a fantastic opportunity and alternative treatment that can really reach these children. And I've had lots of parents be so confused. They don't understand. How is it that a horse can help my kid and risperidone is not helping my kid? So if you can give us some insight into the value of equine therapy, what led you down that path? How do you see that enhancing your treatment now?
Well, if we take a step back, if I kind of take apart your series of questions there, I came into what I call farm animal assisted therapy, and then I did eventually get certified a couple years ago in equine assisted psychotherapy. But I came into this because of exactly what you said, that I was confronted by children who were very complex. And this was not garden variety ADHD. Right. It was not garden variety anxiety, social anxiety, wasn't clearly, bipolar disorder, wasn't, a psychotic episode. A lot of these kids have multiple complex issues, including a lot of sensory issues, neurocognitive issues, executive function problems, impulsivity, attention problems. And social communication problems. So in the traditional office setting that I had been trained in, and I did my residency training at Georgetown with analysts, play therapists. So in doing the play therapy, I found that the kids would get so dysregulated, they would throw the toys at me, or they couldn't process, even with the indirect way of processing that we do in play therapy, they couldn't process the trauma, and would just, become rageful. And so I had the first boy this happened with, he had never had an episode in my office until I had brought up why he was in my office. It was probably the third or fourth session, and just to gently, kind of through play therapy, figuring out why he was doing bedwetting, right? And see if I could get any ideas about it. And he all of a sudden chucked army men and the moon sand at me, and hid behind a very large that office chair. It was my other office, but that was the same chair. And it's a pretty heavy chair for a 7-year-old to be hoisting out, and getting behind. So I then just quickly regrouped and went and got my guinea pigs. And that's how I started working with animals in the beginning, was using guinea pigs. And then worked my way up the food chain, eventually reading a lot about equine assisted psychotherapy. And by then I was already working with goats, and goats are a little smaller, but the same type of animal as a horse, which they're prey. And they're very, gentle with people and friendly. They give, very good social communication if you raise them right, the same way that horses do. And remember, horses evolved with man for the last however many thousands of years, because we use them for hunting. We and goats were domesticated before the horse, my understanding. But in both cases, we've lived with them, and the hunters would hunt with them, but they would use them for warmth. They would bond with them. So the horse would come when the person called them. And horses know how to recognize human facial expressions and body language. And you can gently with your horse, like you can tell him what you need him to do. If he if you've been with him long enough, you can get him to do what you need him to do without hardly even touching him.
Mm.
That's the beautiful thing about doing the work that I do. I know my animals very well, and I've hand raised now 15 goats. We just got our most recent one about 2.5 months ago, who's 4 weeks old at the time, but I've raised them as young as 10 days.
Wow.
They're bonded with me, so they understand me as meh, meh. And many of the bottle babies we've even had in the house when they're really little. So the farm animal assisted therapy is not that different than equine assisted psychotherapy, which is really working with the animal as a co-therapist to help the child feel comfortable. And in some forms of equine assisted therapy, they do hippotherapy, which is the child riding the horse, and typically that's done with kids that are a little lower functioning, that need the kind of proprioceptive help, and it's really an occupational therapy type of experiential therapy, where they ride the horse and they get better balance and coordination, and it gives them confidence. And for some of the kids, they are not mobile, and they're actually put up on the horse, and it gives them mobility that they wouldn't have otherwise. And then there's horsemanship, which is another type of, it's more path oriented, PATH, where they groom the horse, and they brush the horse, and they get to know the horse, and then eventually get to be able to ride the horse. With equine assisted psychotherapy, which is through EGALA, that's the Equine Assisted Growth and Learning Association, that method is one that I've been trained in, I'm certified in, but I don't actually use in clinical practice because it requires an equine specialist to work with the therapist. And so there's 3 people on the team that's working with the patient. There's the horse, who's a big part of the team, and you can use 1, 2, 3 horses, however many you want. And then there's the equine specialist, which is really there to oversee the interactions with the horse, to make sure the horse is safe, to make sure the people interacting are not doing anything in violation of the horse kind of etiquette and rule, right? And then to be kind of a co-facilitator in the sessions. And then there's the mental health specialist within the team. And that's the person like myself. I'm a psychiatrist, licensed, as a psychiatrist. But any mental health professional can be in that role that has the training. And then every 2 years, you have to have, the number of credits to recertify. So having said that, what the sessions involve is, if you do the traditional way that EGALA teaches, is very analytically oriented. So that the person actually goes out into the arena that you have set up and interacts with the horse, with the equine specialists and the mental health professionals standing back and letting the person interact. And it can be with balls or hula hoops or all kinds of things in the arena. And the person brings a problem into that they want to solve. So much of this is done in group work. You can do a lot of group work. A lot of the work has been done with veterans or with even military professionals who don't have a high regard for mental health, and they would be reluctant to go to a mental health professional, but they'll bring in equine specialists to work with them. How it's evolved in my practice is a bit different, because I really just take the kids and interact with the animals, and I can predict my animals because most of them I've hand raised, or when they came to me, like the 2 ponies came from a pony riding place, and a woman had rescued them from there, but they were very gently raised. And I got to know them before having kids interact. And then the same way with the horse, he's a very gentle giant. But, just having the kids go and interact in an experiential way, it becomes more kind of like you would in wilderness therapy, where you take the child into a setting that they're not used to, and then it feels calm and comfortable. And because, the property that I live on is 6.5 acres, we can walk through the pasture and the forest with the goats and with the horses, which most people, even I could ask you, have you ever walked through the forest and pasture with 15 hand-raised goats, an Irish draft horse, and 2 ponies? Have you ever gone and scratched a pig, a 200-pound pig, and let him roll over and let you scratch his belly? These are experiences that these kids have, and like they've never touched a pig, to know that the fur is very wiry and his ears are very soft, and he grunts when you massage his legs. And it's this multi-sensory experience that many people do not get to have. But holding a chicken that's been hand raised, or letting the chicken peck some food out of your hand, for a lot of kids, it's a multi-sensory experience that then softens them because it desensitizes them to other aspects. And at this point, we have 8 roosters because we've rehomed a bunch here. And so at any given time when you're down with the animals, you get used to hearing roosters throughout the day. It's not just in the morning. And so the kids then get used to like hearing a number of different sounds, the horse whinnying, the horse like kind of neighing, hearing the goats bleating, which they don't do that much. But, if you are not used to it even once or twice, it can be startling. So it desensitizes the child and helps them regulate a little bit better. And the children ask to go, in the very first session with the parents, we talk about, the child's interests and their, a lot of people do come to me because I have animals. If the child, I was highly allergic as a child and I went through allergy shots. So I couldn't be around cats as a child. And, I did have a cat as an outdoor cat. But ahead of time, we screen the children. If they have allergies, you're probably not best suited for my practice. Even though in the beginning, like the dog that we got was hypoallergenic, I kind of gave up on, that. And I said, you can send your kid for allergy shots if you really want to come to me. But I think there are a lot of psychiatrists out there that you would be better suited to if your child has allergies. So, yeah. And I think taking care of the animals is another aspect of farm animal assisted therapy, because they are my co-therapists. And one of my patients brought me a little sign that I have on my door. It says, "The best therapists have fur." I have it on my door to my office. But I do believe in that. And it's a different mindset. It's not for everyone. And what I do here at my practice, which is therapeutic and learning centers, I do a lot of teaching about how the brain works and how we have a deep brain that's more like a reptile or a chicken, or now emus. We've got 2 emus.
Oh my
And
goodness.
yeah, and I like saying that we have an inner emu, rather than an inner chicken, because the chicken has a bad connotation. And then we have our mammal brain, which is really our basal ganglia and, more of the limbic regions. And then we have our higher brain, which is our human brain. And it's a growth mindset. It's helping kids grow to a higher level of thinking and helping them understand why we do cognitive and behavioral therapy, because we're trying to get them to move up past the emu brain and the dog or cat brain or goat brain into our human brain, and bring our awareness up to these higher levels and stop and think. Don't act like an emu. You want to stop and think and put a little stop sign right here at your prefrontal cortex and say, hey, I might not need to react to that as quickly as an emu would. I need to act like a 7-year-old little boy. Right. And how would a 7-year-old little boy react to that versus an emu? Right. And just get them to be thinking a little bit different. And by seeing the animals, by getting to know the animals, you can talk with them about that. And then the horse, if we go back to why horses, well, the thought is that horses, and again, they've done studies on elephants and horses both, they give off this vibration, and really studies have shown this. There's huge studies recently in California when they look at the electromagnetic field around a horse, because their heart is so big, they're giving off this signal. And remember, they are prey animals, they're not predators. So unless they've been beaten and racetracked, right, and run around the racetrack, and they respond to the gun going off, and then they have trauma, because they're beaten to run. A horse that's just been gently raised is going to give off a very, lovely vibration. And so when you're around that horse, then you are calmer. It's the same way as a racehorse that you put with a stable goat. I don't know if you're familiar with that, but a lot of racehorses cannot go into their stable or their trailer to go to a race without their stable goat. And that's because the goat then around the horse feels calmer, because the goat has this alpha, he thinks that horse is going to take care of him. So the goat relaxes and then lays down and starts chewing his cud. And the horse then relaxes because he's got his little buddy there, who's all relaxed. And he's like, well, I shouldn't be afraid because this little guy's not afraid. And it's a feedback, it's a resonance, it's it's like through frequency and vibration. And I know these things are like, maybe more metaphysical and spiritual, but I think that is the realm that this stuff works in. It's at a level that we can't necessarily comprehend until we see it
and experience it. And I think most animal lovers and dog owners, cat owners, because most people don't have goats and horses, but I think all of us who do own pets have seen that with our own children, have seen that with our spouses, have seen it with ourselves when we are dysregulated. And I think that's why there is such a connection between having emotional support animals with us, for those of us who deal with anxiety, who deal with other sorts of difficulties, because we can be regulated in part by being with our animal spirit, who's also regulating. And I think that parallel goes with the parent-child dynamic as well. It's almost like the horse is the parent, right? And then the goat that you're talking about is the child. And if we can, through that resonance that is inherent to us having our child, whether they are our own biological child or adopted or fostered, when we care for someone, especially something smaller than us, we have that feedback within ourselves, that maternal instinct, and the child wanting to be regulated by us as well. So that's why it's so important, as you said earlier on today, that we focus on parents learning how to regulate themselves and be that example of this heart with a big horse. We can be that heart with a big horse and give off that energy to help our child to calm themselves. Not always, but being that example builds that habit. And another thing I want to touch upon with how you were speaking about the children on the farm and your patients learning from the different farm animals was how having a relationship with something other than you builds your own awareness of self, especially as children, where things are so concrete. These higher cognitive levels of speaking about distortions and thought patterns, defenses, it's very difficult for kids. But when they see, oh, if I press on the chicken too hard, it's going to peck me back. Oh, maybe I shouldn't curse at my dad. Oh, maybe I shouldn't hit that other kid in my class because they're going to hit me back. You'd rather them learn that lesson with a chicken than with another peer.
Yeah, and I've got it. It's so true, Dr. Naidoo. We have this one goat, his name is Rami, but people mistakenly call him Rammy. In fact, if you see our local cable channel came and interviewed me, and they took pictures of him and did video, and it's on the internet. And they called him Rammy because he likes to jump up and ram another goat like that. But he also occasionally will ram somebody else. He has reactive attachment disorder. His birth mom rejected him and would feed his sister, who's a fainting goat. Her name's Rosie. And she would push him away, and she had to be tied to a milking stand to actually nurse him, which is how we ended up with him and Rosie. But having said that, because he got treated that way by his birth mom, he then will, hook his horn around me, pull my leg. And occasionally he'll like butt into somebody. And you've heard of goats doing this. None of my goats do that except for him. And so certain of the kids in my practice have learned a lot about themselves through him. So there's two examples I want to bring up. One is he was trying to get at this one 14-year-old girl, and she was doing everything she could to dart around. And like a lot of children with reactive attachment disorder, he does it to get attention. He wants somebody to scratch him and rub him and get between his horns and, right here, under his ears. And she was darting behind trees and, trying to get away from him. And I later asked her, how did that make you feel? And right in the middle of this, because we were still out in the pasture when I was asking her, how is that making you feel? She said, I think this is how my parents must feel when I come after them, pounding on the door and screaming and yelling at them.
Yes, exactly.
So that's insight. So when we talk about what separates mental illness from no mental illness, I don't even like the term mental illness, but I'm just going to use it because society uses it, psychiatrists use it. I don't like it. Okay. What separates it out, besides are they functioning at home, school, and the community, is do they have insight? Okay. Now, if they have insight, then that brings what? The chance for recovery, remission, change, right? But if they have no insight, so how do you give them insight? Well, that's how. Now, another really great example of how Rami, not Rami, but unfortunately he gets, and I always say, oh, they changed his name in the episode for HIPAA reasons. Because he's really here getting therapy. But anyway, so he was here and I was out in the pasture with this little girl who was with her dad at the time and explaining her emotional rages in the morning getting ready for school, because she was so dysregulated at school that she did not want to go. It was overstimulating. She was in the wrong environment. It was just not good. And she was on the spectrum, but very, very high functioning, very, very bright girl. But was getting to the point where when her parents arrived at school, she would literally take all her clothes off in the car. And the school traumatized her by, like, they would put something around her and actually take her into the public school that way, which I was horrified when I found that out. Okay. But having said that, we were out in the pasture, we were talking with her dad, and he was, they were both explaining what was going on. And Rami all of a sudden came up and like whapped her on the behind.
Oh my gosh.
Horns. And then her dad said, oh, that looks a lot like what happened the other morning between you and your mom. Isn't that interesting? And sometimes in these sessions, the animal will act out what they are sensing you're feeling, right? They, instead of coming and like you see your dog or cat do when you're sad or something like that, if you're agitated or angry, sometimes they will pick up on that vibe and they would do that. So yeah, I think it's not a different way of analyzing things, because I still analyze the child in this form of therapy, but maybe it is a different way of analyzing, but it certainly provides insight. Like you were saying, it gives them insight on how other people feel. It gives them more compassion. Like the guinea pig in the beginning that I had talked about, if they squeezed it too tightly, like you said, with the chicken, it might peck them. With the guinea pig, it would squeak, and giving them that immediate feedback. So yeah, it's just been really fun and wonderful to see this type of therapy blossom with children. And they come back and they enjoy their sessions. They never, if a child doesn't like it because they don't like animals, or they don't appreciate the outdoors, or they don't like gnats and they can't get over that, it's not necessarily the right fit.
Right.
But there are so many other really great psychiatrists in our area. I just, refer them.
Yeah. Well, I can imagine listeners smiling, thinking about the stories that you've told about Rami. And I think that it's just a wonderful, new opportunity to really blend different types of therapies, modalities in your practice. I think it's a wonderful and very unique way to reach kids. And we all need to find ways to reach kids. So I know I want to be respectful of your time. The last major question I want to ask you was about Fetal Alcohol Syndrome Awareness Week, Awareness Day, sorry, that's coming up on September 9th. If you could tell us a little bit about that day and how listeners who are interested in this topic can get involved and support the cause.
Well, so fetal alcohol spectrum disorder is different than fetal alcohol syndrome. So fetal alcohol syndrome is really and we were going to talk about that, I think, a little earlier. I might have mentioned it, but has the facial features, the growth retardation, meaning at or below 10th percentile, and has neurodevelopmental issues. So if you have all three facial features and the growth impairment and neurodevelopmental issues, you get fetal alcohol syndrome as a diagnosis. The other diagnosis is ND-PAE, and they are both up under the umbrella of fetal alcohol spectrum disorder, which is kind of like saying autism spectrum disorder, whereas autistic disorder is the diagnosis. So fetal alcohol spectrum disorder awareness day is what it's known as. The first day that they commemorated it was 9/9/1999. And
Oh,
that was for the 9 months of pregnancy. Like, be aware that alcohol can affect a pregnancy at any point in the 9 months. And it was established by Bonnie Buxton, who just recently passed away this past summer, and her husband, Brian Philcox, in Toronto, Canada, on really behalf of their daughter, Colette, who they had raised. And she had been adopted when I think she was 3 or 4 years old. But they didn't find out till she was already homeless, living on the streets of Toronto when she was like maybe 17 or 18, that she had this condition. And once they learned about it, it was through Bonnie, who was a writer, a journalist. She happened to be watching TV when they were talking about fetal alcohol spectrum disorder and realized that all of the things they were talking about, her daughter met. So Fetal Alcohol Spectrum Disorder Awareness Day, they founded, and now it's become an international movement. So if you just Google FASD Awareness Day, you can put in FASD United, which is the new, I guess, name for National Organization on Fetal Alcohol Syndrome, or Proof Alliance, PROOF Alliance. It used to be the Minnesota Organization on Fetal Alcohol Syndrome. They're also very big. But the Centers for Disease Control does, a lot around FASD Awareness Day to raise awareness. The National Institutes on Alcohol Abuse and Alcoholism, they do a lot to raise awareness. And I can send you some links about that. But if you just put in FASD Awareness Day 2023, you'll be able to find out a lot because people are writing a lot about it. And it's largely now spearheaded, just like the founders, by parents of affected children. And a lot of the parents are adoptive parents, because many of the birth parents either are too ashamed, which I can imagine there's a lot of shame associated, to kind of be involved, which I always say we cannot blame the parents. We can't blame the biological parents, because it's the alcohol industry we need to get behind and hold accountable. And I wish that whole population of people, which is biological parents of the children, could do more. There is a circle of hope that is run through FASD United, and they are birth mothers who are trying to, I guess, form support networks, and they have some support groups, and there's a lot of online, like, Facebook pages of the community. Some of them are individuals affected by FASD, and others are individuals who are the caregivers. Some are researchers who research the topic. But I think the more that the public can kind of question, this whole issue. And don't believe me. It's just like, when I was growing up going to church, I was always trained to ask questions. Don't just accept, the gospel, for instance, quote unquote. And we got to expand our understanding of all kinds of things and keep getting an education about it. Don't just drink a beverage because you think it's going to numb you out and to regulate you better, or cause you not to think about your problems at the moment, or because you feel like you need it to socialize. Why are we doing this as a society is what I want people to start thinking about. And FASD Awareness Day is a day to make people more aware that this is the leading probably preventable and known cause of neurodevelopmental problems. And it's affecting a large percentage of our population because it occurs very early in pregnancy, late third, early fourth week, and 50% of pregnancies are unplanned. And 13.5% of childbearing age women binge drink. That's 4 or 5 drinks in a given sitting. And that's enough. That 4 to 5 drinks in one sitting is enough to cause the full-blown fetal alcohol syndrome if it's in the late third to early fourth week, and it's well before anybody knows she's pregnant.
Right.
So FASD Awareness Day is September 9th every single year. And most states, most countries have now designated that as an official recognition day. Wonderful. So yeah, people could get involved by, clicking on any of those links that I mentioned, and hopefully we can continue to raise awareness. That's what it's all about. And to make change, not just awareness. Awareness creates an opportunity for change. And that's what I think it's all about.
Absolutely. So how can our listeners get in touch with you?
Well, I would suggest through my Facebook page, which is at Susan D. Rich, MD, or my nonprofit, Seventh Generation Foundation at gmail.com. I do these public, speaking arrangements. I, will go out and talk to groups of people, and any honoraria for that then go back to my nonprofit, Seventh Generation Foundation.
Wonderful. So we'll just round out with my my ending I usually do, rapid responses to a few questions, if that's okay. So what are the top 3 things you wish you knew before you became a psychiatrist?
Well, I think we talked about one of them before, which is that I would have to give up some aspects of my public health aspirations, because some of those are in conflict with being a psychiatrist. Yes. And I also wish I knew beforehand that psychiatrists are not necessarily some of the most well-respected people because of some of the things that have happened historically in Eastern Europe and other countries. I wish I knew more about the history. I would have still become a psychiatrist, but it might have prepared me for learning some about the history of psychiatry. And I wish that I knew how much psychiatry had evolved into psychopharmacology, where, we have really been relegated to being medication pushers. Right. Versus, and I'm not saying all psychiatrists are that way, and certainly the people I trained under were not that way. But I think as a field, I feel a little bit like a redheaded stepchild sometimes when I go and talk about doing therapy with patients, because so many psychiatrists are on a 10-minute, clock. Right. With their patients. And I spend an hour, my first visit with parents is for an hour and a half. And I feel like that's, like people look at me like I'm strange that I do that. So I wish I knew that.
Well, I hope people listening hopefully are hearing that there are psychiatrists like Dr. Rich and myself who do much, much more than medication management, a term that makes me cringe, because there's so much more that we can do. It's not just about medication. Anyway, but what's the best advice you've ever been given?
Well, my grandmother who raised me had a sixth grade education, and she told me there is nothing I can't do if I put my mind to it. And I know that's a phrase that a lot of people use, but I believed it. And she also told me, keep on getting my education, because there's nothing, that's the one thing no one will ever take away from you.
Mm-hmm.
And it will get you beyond any obstacle. She had a sixth grade education, and she taught me that. But I've also been advised by my supervisors who were female. A lot of my supervisors were female and had home offices, to always have a cleaning crew.
Mm-hmm.
So, because we don't need to be doing that ourselves. And I do reimburse my cleaning crew well. And I also give them a nice tip. And really it makes my life so much easier, not having to clean my own house.
So if you could answer or finish the next couple sentences, the most important thing in life is?
My children. My children, who are now 20 and 17, are the reason I get up every day, aside from 15 goats that are screaming at me from my backyard, and a bunch of roosters. But I think my kids have grown into amazing, resilient, kids, despite and in spite of and despite some of the things that have happened to us. I think our children are our future, so we must protect them at all cost. And I think that's all children. We need to begin thinking about it even before we get pregnant. Preconception health.
The most important thing in life is your children. The most rewarding thing about being a psychiatrist is?
I love helping kids find their superpowers. And I love, the idea of watching them grow into their superpowers. And even if they're highly sensitive, or they have very strong reactions to things, or they butt heads with their parents, teaching them that these are superpowers that they have to learn to harness themselves, and then to watch them as they flourish and watch them go on. I've had so many that go on to graduate school and professional school. It's just been so incredible. I enjoy that.
I wish my struggling patients knew that
They do have hidden powers, and that it's their powers that they're afraid of, and that some people are afraid of, the same way that the Marvel superheroes, the X-Men, and Mrs. Peregrine's Home for Peculiar Children.
Mm-hmm.
Same deal. I wish that they knew what light they have in them, and not to be afraid of their light. The darkness can overtake the light, but if they can really embrace their light and let it shine, no matter what, they will do great in life.
And finally, the future of mental health care will be?
Well, I think it's going to be less stigmatized, because I think those individuals who are neurodiverse, they are coming out and they are letting people know that just because they have differences, it does not make them better or worse. Okay. And it's just like when we were in middle school and we had to go through middle school with frizzy hair and buck teeth. I'll never forget it. It is not very pleasant, but if you have a good brain, they might call you a nerd. But nerds rule the world. And I think people are beginning to understand that, and that neurodiverse is not there. It's not psychopathology. What separates, and I think that's where we need to embrace that as our psychiatric community, that will be a change in the next, I would say, 10 years, that we're going to get rid of that term. That's a hope, but I do think it's going to happen. And the other thing that I think is going to happen is we're going to start preventing some of the neuroteratogens from causing neurodevelopmental birth defects. They're called neuroteratogenic birth defects. So that's another thing. And the microbiome is going to be more of an influence on how we practice, and getting kids outdoors around many different species of bacteria is super important for our microbiome. So the more we understand the influence of our microbiome and the influence of nature and One Health, which is that our health, our human health, is inextricably linked to environmental health. And we as psychiatrists and public health entrepreneurs embrace One Health, I think more people will be changed. So that's, changed in a good way. That's what I'm thinking.
Well, Dr. Rich, you have such the perfect name. Dr. Rich, what a rich, full, in-depth conversation about so many things. We talked a long time and we could talk for longer because there's so much that you know. You're a wealth of knowledge. Thank you so much for spending the time to chat with me and with our listeners. I really appreciate it.
Thank you. Well, it's been a pleasure, Dr. Naidoo, and I hope to stay connected in the future, and hopefully we'll come back to Arizona, to your beautiful, beautiful state in the spring again, like I did this year.
Absolutely. Be well.
Okay, be well. Bye-bye.